My presentation is on rational use of NOACs for stroke prevention in people with non-valvular atrial fibrillation. I will confine my discussion on SPAF and not on venous thromboembolism. Now, if you look at the prevalence of atrial fibrillation in India, we said it was much less mainly because of the lack of awareness, lack of high index of suspicion, and lack of screening modalities. It was 0.5. However, recent literature shows that it has increased to 1.6%. However, active burden of atrial fibrillation will be definitely much higher than the literature says. And people above 75 years, it is 5.6%. Again, atrial fibrillation disease of old age. As the age advances, the prevalence of atrial fibrillation also increases. Then Professor Braunwald, in his recent review, has identified atrial fibrillation as an emerging global epidemic. Atrial fibrillation, as we all know, is not benign. The worst thing about atrial fibrillation is not the arrhythmia per se. It produces disabling stroke. There is a 5-fold increase of stroke in patients with non-valvular atrial fibrillation and 17-fold increase in stroke in people with valvular heart disease. Stroke and vascular dementia is going to affect at least 1/3 of the population. It's a statement by John Eckelboom. So he re-emphasized what Braunwald has said. It is going to become an emerging global epidemic. Now, this is an interesting study around 1,400 odd patients with non-valvular atrial fibrillation with absolutely no history of stroke or transient ischemic attacks. And they were subjected for MRI brain. And surprisingly, 20% of these patients had small lacunar infarcts, cortical strokes, subcortical white matter stroke, and microbleeds. So all these produces cortical dementia, subcortical dementia, gradual cognitive decline. So what we see as a clinical stroke is only the tip of the iceberg. There's a large number of patients who develop subclinical small strokes, which adds to dementia. What are the AF-related outcomes? It produces death, stroke, LV dysfunction, gradual cognitive decline, depression, impaired quality of life, and frequent hospitalization. About 25% of all ischemic strokes are due to atrial fibrillation, and 10% of cryptogenic strokes are due to atrial fibrillation. So it needs a high index of suspicion, and we should have a lot of screening modalities like Holter, extended loop recording, so on and so forth. Now, so far we have been using vitamin K, and the Garfield AF registry is the largest real-world registry using oral anticoagulant in patients with atrial fibrillation. Almost 52,000 patients were there. Almost 1,400 patients were from India. So what we see surprisingly is that it is a very poor control of INR. Only 1/3 of the patients had INR in the therapeutic range, and only 1/3 of the patients had TTR of more than 70%, which is the required TTR. But come to this side. See, that is surprisingly, it has shown that it is not if you see patients with a very high elevated INR of more than 4 and less than 1.5. More than 4, the stroke rate was 3.5% per year. However, all people who are under anticoagulated, where INR is less than 1.5, there's a very high incidence of stroke, 7.2. It is not the ischemic stroke alone. Some patients develop bleeding also. So under anticoagulation is much more dangerous than over anticoagulation. That's what the real world data shows. So poorly controlled INR level with warfarin may cause more harm than no treatment with anticoagulants. So non-valvular atrial fibrillation, as we all know, is a misnomer. Non-valvular atrial fibrillation means absence of mechanical prosthetic valves and moderate to severe mitral stenosis. Other valve diseases like AS, AR, and MR, all we can give NOACs. Now, coming to the NOACs, we all have apixaban, the Aristotle trial, rivaroxaban, the rocket trial, and the dabigatran, the relay trial. Now, if you do the comparison, the summary of the trials, all these trials had two primary endpoints, that is the safety endpoints and efficacy endpoints. Both are equally important. The safety is as important as efficacy. And what did the trial show in summary? It has shown that the apixaban produces 21% reduction in stroke and 31% reduction in the bleeding risk compared with warfarin. Look at dabigatran 150 milligram. It produces better reduction of stroke than apixaban. However, it produces 34% reduction in stroke. Apixaban produces only 21%. But look at the bleeding. Bleeding, it produces only 7% reduction in stroke compared with warfarin. So, apixaban produces significant reduction of ischemic stroke, and it is found to be absolutely safe. It is very, very important in our day-to-day clinical practice, because any bleeding with a drug is not well accepted by the patients. It has got a lot of medico-legal problem and everything. So, if you select the net clinical benefit, apixaban has got the best net clinical benefit. It is found to be the safest NOACs available. Now, coming to Aristophanes study, it is the largest real-world data with NOACs. More than 4 lakhs patients were included, and that study has again complemented what information we got out of randomized control trials. All these apixaban, rivaroxaban, dabigatran were found to be better than warfarin in reducing the stroke, and apixaban is found to be the safest as far as the bleeding episodes are concerned. Now, what about NOACs versus NOACs? So far, there is no direct comparison with one NOAC to other. However, this real-world data has given us some clue and to compare apixaban with rivaroxaban and apixaban and dabigatran. Again, it has shown that it produces more or less equal reduction in ischemic stroke, but safety is highest with apixaban. So, apixaban is the safest NOACs available. Look at rivaroxaban. Treatment with rivaroxaban compared with apixaban is associated with significantly increased risk of major ischemic and hemorrhagic stroke with a hazard ratio of 1.13. So, a meta-analysis of NOACs with improved outcome has shown an improved outcome compared with vitamin K. It produces about 20% reduction in stroke, a 14% reduction in major bleed, 50% reduction in the hemorrhagic stroke compared with warfarin, and 52% reduction in intracranial bleed, 10% reduction in all-cause mortality. Look at GI bleed. GI bleed is found to be slightly higher with NOACs compared with warfarin. And GI bleed was highest with rivaroxaban and least with apixaban. Now, what will happen if you give inappropriate underdosing? The Garfield registry has shown us very clearly that underdosing produces much more harm than not giving the drug at all. However, what about this NOACs? Again, the same. Underdosing. See, look at the apixaban. If you give underdosing, the event rate per 1,000 people, it is 2.5. If you give the standard dose, it is 0.5. Look at bleeding. Even if you underdose, the bleedings are much higher. So, underdosing produces much more harm than not giving the molecule. So, we should all emphasize the patient that you should take appropriate dose, the correct dose, the standard dose. Now, we know the atrial fibrillation associates a lot of comorbidities like diabetes, hypertension, cardiac failure, obesity, and all comorbidities increases as the AF progresses. So, the risk assessment of atrial fibrillation should be dynamic. For example, you give dabigatran to a patient with a normal renal function. After 6 months, his creatinine may increase. If you are not reducing the dose of dabigatran, he may develop bleeding. So, risk assessment should be a dynamic process. Each time when the patient comes for a review, you have to do the risk assessment. Now, how to manage anticoagulation in patients with comorbidities? The commonest comorbidity is elderly people, because AF is a disease of elderly. Look at people above 80 years. Above 80 years people are less represented in most of the randomized control trials. Above 80 years, the apixaban is found to be as effective as people less than 80 years. Look at the major bleed. Major bleed above 80 years, the hazard ratio is much less than the people above less 60 years. So, this shows that apixaban is absolutely safe in people whose age is above 80 and so. This is again complemented by the Avaros trial. It's a randomized control trial where they use apixaban versus aspirin. Now we know that antiplatelet has no role in atrial fibrillation for stroke prevention in patients who had contraindications for vitamin K therapy. Again, look at the patients above 75 years. The apixaban is much more beneficial. So, contrary to our belief, we think that if you give apixaban in elderly people, it produces more bleeding. However, both the real world evidences and RCT has shown that it is much more effective in elderly people. So, we can safely use. What about rivaroxaban in elderly people? Up to 75 years, okay. More than that, efficacy comes down and safety, it produces more bleeding. Now, what about dabigatran? Dabigatran produces more of extracranial bleed in people above 80 years in the standard dose. So, as far as the safety is concerned, apixaban is the most safest NOACs available. Now, what about chronic kidney disease? Chronic kidney disease is a unique condition where they have got a high ischemic risk and a high bleeding risk. And it is an independent risk factor for thromboembolism. Unfortunately, it is not included in the CHADS score, and there is an R2 CHADS2 score where the renal failure is also included in the risk assessment. This is the R2 CHADS score where the renal dysfunction, they have given 2 points. It gives us better assessment of the risk of the patient for stroke. The renal failure, apixaban, because only 25% apixaban is excreted to the kidney. However, 80% of the dabigatran is excreted to the kidney. So if the GFR up to 30, you can give dabigatran. If GFR is less than 30, no dabigatran at all. Rivaroxaban up to 30, you can give. Less than 30, you have to reduce the dose to 15. However, apixaban, you can give till the whole stages of renal disease, including patients who are on dialysis. However, we have to use this ABC scoring system. That is A, age more than 80, B, body weight less than 60, and C, creatinine more than 1.5. 2 of the 3 criteria is a dose reduction criteria for apixaban. In short, if a patient has CKD alone, you should not reduce the dose of apixaban. He should satisfy 2 of the 3 ABC criteria. Look at the bleeding with apixaban. If the GFR comes down, actually, we think that they will bleed more. Actually, the trial showed that they bleed much less compared to the other score. Again, it shows the safety of apixaban. Look at, there's a study which I conducted, eGFR less than 30 and more than 30. Less than 30, the bleeding and stroke even is much less compared with more than 30. This again re-emphasizes the safety of apixaban in people with CKD. Now coming to the bleed, the bleeding, GA bleed is much less with apixaban compared to other 2 NOACs. And GA bleed is more common in people who are taking concomitant aspirin, NSAIDs. So you should avoid all these things, and you should consider PPI in high-risk patients. Usually it happens within 2-3 weeks of starting the therapy, and major GA bleed occur in those people who are previous history of GA bleed. You must control blood pressure very well in these patients. Controlling blood pressure is an opportunity to prevent stroke in such patients. What about extreme obese patients, more than 120? We sometimes see patients of 130 kilos, 140 kilos. Whether we should use a standard dose of apixaban or whether we should increase. Studies have shown that you should not increase the dose. We should use the standard dose of apixaban, that is 5 milligram BD. What about stroke? The recent stroke was an exclusion criteria for most of the pivotal trial with NOACs. Now, all of us follow this 1-3-6-12 rule, that is the Daynes law in stroke. That is, the patient had a TIA, after 1 day, that is after 24 hours, you can restart apixaban or you can start apixaban. However, patient with mild stroke, moderate stroke or severe stroke. How will you classify mild, moderate, severe stroke? If it's the MCA territory, less than 1/3 of the MCA territory is involved in the CT scan, 1/3 to 2/3 moderate, more than 2/3 is severe stroke, or you can ask the NIH stroke scale of less than 8, 8 to 15 and more than 18. So you start it after 1 day, 3 days, 6 days and 12 days. And you do a CT follow-up. Now, this all of us know the Augustus trial, where the use of, where you do a stenting and with atrial fibrillation, how will you use? You give the triple therapy for 1 week. After 1 week, you drop aspirin and continue only a P2Y2 inhibitor and apixaban. However, if that patient has high ischemic risk, like left vein stenting, bifurcation stenting, venous graft stenting, or more than 3 stents used, more than 60 millimeter length stented, so on and so forth, high ischemic risk, you can use it for 1 month. But after 1 month, never continue the triple therapy where the chances of bleeding is very, very high. Now, the reversal agents, these are the reversal agents which you use. However, the time is the best antidote for NOAC. You wait for 24 to 36 hours, all the bleeding will stop. Seldom we use all these reverse agents. Now, this is a study where they have used reversal agents, that is the prothrombin concentrate, idraxumab and antixinate alpha. There is no difference between the death, thromboembolism and hemostasis. Then DOAC use was associated with lower incidence of dementia compared with non-use. Now, AF burden. Now, here you see, if the CHADS score is more than 2 or more than 3 female, you definitely give anticoagulation. But look at a group of people where CHADS score is 1, but AF burden is high. Such patient also should be candidate for NOACs, and it should come into the guideline. So, AF burden is as important as the other parameters. So, this is the guideline says, this is the doses. Apixaban 5 milligram twice daily, apply the ABC criteria for dose reduction. Dabigatran and rivaroxaban, if there were renal dysfunction, you should reduce the dose. Now, a patient age more than 75, high bleeding risk, previous bleeding risks, apixaban is the drug of choice. This is an article which came in November last month in Annals of Internal Medicine, where they did a data analysis of 10 years, more than 5 lakhs patients, that re-emphasized that apixaban is the safest Novox, especially in elderly patients, CKD and previous bleed. Now you have to select a sweet spot, the net clinical benefit. So in that, apixaban scores. So the safest Novox, the highest clinical benefit, best in patients with comorbidities, advanced age, CKD, obesity and GA bleed, broad spectrum of patients. Humanity's greatest advance are not in the discoveries. It all depends upon how the discoveries are applied into the day-to-day clinical practice. Thank you very much for your attention.